Good afternoon, everyone. I'm Dan George, and I'm going to take you through part two of the 2026 Palmetto-GBA Hospice Workshop. Thank you for joining us today. We're glad to have you here. We're going to get started right away because I'm a long-winded talker when it comes to hospice. Um, we did home health this morning, and I have a little more uh, feeling for hospice, I'll say. When my mom switched to hospice from home health, she was excited when she went from switched and elected hospice because she had no longer had to exercise doing her therapy work. So she was very happy not to be doing exercises. So I remember that very fondly, and and that's always going to stick with me. All right. So as we move on here, disclaimer, of course, we put this presentation and got it to the associations back on April 13th, last Monday. So everything was up to date at that time. So if you want to keep up to date after this, please make sure you sign up for our email updates on our website. And I'm sharing our website now with you. Just go up here at the top at any place at home, but I'm on the Palmetto GBA HHH page. Click on the email updates. You enter your email address, confirm your email address. You can unchoose them all or unselect all the options and just do hospice if you want. If you do home health agencies, you want. If you do general, you can put that on. Make sure you hit submit, check you're a human, and you'll get a confirmation email sent to your email address. Make sure you use the link provided to confirm your registration. We won't inundate you with emails. We probably do one a day unless there's an emergency for some type of information. And along with that, we advertise all kinds of events that we may possibly have going on, which would be under our events and education calendar, where you can view all events. I was mentioning this morning, I'm doing a home health notice of admission webinar tomorrow at 2 p.m. Eastern time. Uh, Look for a hospice notice of election one coming up in May. We haven't put it out there yet, but we'll put it out in our email updates as soon as we get that going, and you can sign up for the notice of election webinar where we'll really tackle the ins and outs of the NOE. So please sign up for that to stay posted with all the new information. We'll forward out CMS information and all that type of information. So we'll start here with the agenda, the 2026 final rule summary. We'll go over that. We're half a year already through that. Most of you are used to it, so not too big of a deal there. But recently they put out the 2027 proposed rule. So we're going to go over what they proposed. And we'll talk about that. It's just one slide that we talk about it. We really don't get discussing about how that will work because it's just proposed at this time. We can't say how something will be worked or implemented until they actually put it in a final rule, and therefore it's going to go forward. And usually we get some kind of change request or some type of information of what's going to affect Palmetto GBA as a Medicare administrative contractor. So we have updates and reminders, live discharges. This is a big deal. I'll talk about it when I get too many hospices aren't discharging or doing the live discharge correctly, and that becomes a lot of dispute. So we'll talk about that for a little bit. Edit, prevent overpayment of long-term stay in hospice. Editing for outpatient services provided to hospice enrollees. Period of enhanced oversight and expanded prepayment review of existing hospices in those 6 states. We'll talk about it because it just expanded. It was 4 states, now it's up to 6 states. And we'll talk about that a little more, what's going on. The big thing, and Charles mentioned it earlier a couple times, is the hospice cap overview and how the cap actually works in that information. Now, the actual equations behind it and the information behind it is difficult. So you need different reports to go in with your payments and that type of information to get your cap information. So we'll talk about it, but what really is the cap we are going to go over, especially the aggregated cap. The newest e-services tools and updates, along with other information about the e-service portal. We're always going to talk about our portal. Every Medicare administrative contractor, and I'll probably start saying MAC from now on, has to have their own self-service portal. Ours is called e-services. We provide a lot of information. It's constantly being updated. Some of the feedback you give on those surveys, we look into and try to make it better. And some of the things that we just did are from surveys and feedback from providers. So we do look into that and see what we can update and look at. We'll do a quick overview of targeted probe and educate. I know Charles goes over the denials, that type of information. We'll quickly go over provider enrollment reminders, which includes the revalidation. What happens if you don't revalidate is called a stay of enrollment. If you don't do it timely, and if you don't act on the stay of enrollment, it could cause a deactivation from your billing privileges. Then we have the cert at the end and resources for hospice providers. And I'll keep an eye on to the left here to see if any questions come through. So I always attach the fact sheet for the final rules. This gives you a high view, a nice explanation of it, friendly, compared to the full publication of the final rule. The final rule could be 50 pages. The fact sheet is 1 page. It's still, about 10 minutes of reading, but it's not the whole 50 pages when they publish the final rule itself. The final rule can be, like I said, 50 pages. A lot of time, the final rule talks about historically where we were and why we're making this change. And it goes over the comments. So there's always a comment period of 60 days after the final rule, proposed final rule is put out there for providers, associations, and anybody else to make comments to CMS about their thoughts on the final rule and what's being proposed. So with that, the payment update was released in ML Matters 14190 and its sister change request of the same number. So basically what that goes over is the payment update nationally was 2.6%. When the proposal came out, it was 2.4%. So that's been happening the last few years when it comes to hospice. What they proposed is less than what they actually approve at that time. So it's been a little better than what they proposed. And that 2.6% is also what the annual cap goes up to that year also. And again, we'll break down caps a lot more as we go through. That's a big section of this presentation, is talking about the cap and the effect of caps, how that works. So make sure you're always checking every fiscal year that it changes, that we have the payment update to see if your core-based statistical areas, known as CBSA codes, have changed or transitioned for the next year. The places you can find those, the best place is the hospice rate calculator. It will bring you up your CBSA code for your county, for your area. If you're not listed, your county's not listed in your area, there's one to use for the rest of the state that's usually at the rest. So that hospice calculator gives you a lot of information. It's very simple to use. It figures out all 4 level of care rates, plus it breaks down routine home care for the first 60 days compared to day 61 and after. And I say that a little bit there, day 61 and after. If there's a transfer in those first 60 days, that counts as 2 days. So it actually goes down to the lower rate on day 60 instead of day 61. Since both hospices are getting payment for that day, it counts as 2 days. So that hospice rate calculator on our website is something great. You go under tools, hospice rate calculator, you select the time period. I'm going to select the current year. You got to make sure you do that because otherwise you're going to come out with the wrong payment. Have you selected quality data? If you haven't, that's a 4% reduction. And please select the state. So I will go with Louisiana. And then this is what happens. For grants, let's see, Baton Rouge, if you're in the county of Assumption, Your CBSA code is 12940. The wage index factor that goes in there is 0.08. So we look at the national rate, you times that by 0.08, and you come out with the $201.60. So it shows those two rates. Continuous home care, that's the biggest reimbursement per day we'll give. You can see that's $1,428. Respite is $469 and GIP is $1,050. And it even breaks down your service intensity add-on. So this is always good, a nice little calculator to look at. Now, again, it may be off by a couple cents of your actual payment. So you got to make sure, I mean, it's very close. It's just that these things, these wage index and these factors are not, we round it down in this calculation to the nearest 100th, but they're not calculated out to the nearest 100. So it may be off a couple cents, but it's going to be really close, if not real on. So that's the best place to find to make sure you're using the proper CBSA code. I always talk about this, and it was a Mississippi provider I had to call. This goes a few years back now, that we were doing an audit at Palmetto-GBA in our reimbursement department. They sample claims to make sure providers are getting the right payment, and they came across a Mississippi hospice that was using an incorrect CBSA code, and that incorrect using that, it was still a valid code. That's why the system didn't edit out. If it was a wrong code that doesn't exist at all, that CBSA, of course, the claim would be returned for an invalid CBSA code. But if it's still a good code, it still could be processed through, and the claim wouldn't edit for the agency using a wrong code. But in this case, it was $3 to $4 a day they were being shorted on routine home care in the payment. So if you times just three by a 30-day month, that's $90 a month for all their patients. They were using that CBSA code they were losing. So depending on what your census is, that could be a lot of money. So make sure you're checking your CBSA codes on an annual basis to see if there's any changing. Okay, so it's admission to hospice care. It also finalized changes to the regulations to add the physician member of the interdisciplinary group may recommend admission to hospice care. Again, this says aligns with the current certification regulations and the conditions of participation in the Code of Federal Regulations. So really, it's just didn't change what we do. We always were going by that. So it didn't affect us. And of course, this is a condition of participation. Condition of participation are overseen by your state surveyors. That's what they do. They do that. When it comes to conditions of payment, the COP of the other type, that is Palmetto-GBA. Were the certifications done timely? That's a condition of payment. We'll check on that. Did they meet the level of care billed? Billed GIP, was everything there to back that billing of GIP that the patient was on the correct level of care? Those are all petitions of payment. That's what we do. Conditions of participation is more on the state side. Okay, so this is the proposed rule. For 2027, which starts on October 1st, they propose an update to the hospice payment rate by 2.4%. Again, that could go higher, as it has in the last, since pretty much the pandemic, since early in 2021. What they proposed was less than they actually went in the final rule with, so that could possibly happen again. Service and spending variation index they were talking about. The proposed mandatory hospice election statement is an interesting one. And we're going to talk about a new change request that's going on, an edit on hospital claims. We're going to talk about it, and does that affect hospices or not? Not really, but we'll talk about that CMS is checking more for spending outside the benefit. They're really looking at patients or beneficiaries that elect the hospice benefit and looking at payments from other providers outside of the benefit, more Part A and more Part B. When they implemented the election statement back in 2020, they thought they would see a decrease of spending outside when you're telling what's included, what's not included, and it's actually increased even more. So CMS is really starting to look at and looking at different ways to make a change in that effect about the outside spending. So there's a lot of outside spending where other provider types are putting coding on the claims to get past the hospice edit to provide their services. So they're really looking into starting to doing that. And I'm going to talk a little bit later about one of those items that are going on a hospice claim. And hospice quality reporting, they always talk about that, but we don't do that often. So we don't go over the hospice quality reporting. That is something CMS would handle and other contractors, but there could be changes that they're talking about that you'd want to know. Again, I connected a fact sheet for you in that handout, so that is available for you. Hospice updates and reminders. The first reminder here is some of the biggest disputes that go on between hospice providers and technically other providers and beneficiaries. More beneficiaries are going to CMS about their still being on hospice after they've been discharged for a while, that they've been off it. They're complaining because they're going to other providers, and those other providers are saying, you're on hospice. We're not going to serve you because we believe it's related to your hospice term prognosis. So this is a big thing. It's the most disputes we get out of everything. Every hospice MAC, the three hospice MACs, which is Palmetto-GBA, CGS, and WellPoint Federal, which used to be NGS. They just changed their name back on April 1st. So it's no longer NGS, it's WellPoint Federal. These are the biggest complaints all of our MACs receive, is that there is a requirement in a live discharge that the hospice discharge them within 5 days of that live discharge, because it could affect that patient getting medical services due to open elections. It could affect another hospice if that patient is electing with another hospice, and may cause a late notice of election payment penalties for reelection. The only thing we can apply a penalty to is if the hospice discharges the patient alive and that hospice fails to submit some type of discharge, either a final claim or a notice of termination within 5 days, and that patient reelects with that same hospice later, if that was not done properly and it makes their notice of election late, that notice of election will be penalized. That payment will be penalized when the readmitting hospice is the same that discharged and they did not submit that discharge information within 5 days of the live discharge. So that's the only penalty we can do it at this time. There's no other ways to do it at this point. But we want to do this. Email updates, if you've been receiving them, you've been seeing this article come out. We've been shooting this article out every other week, and we're going to at least be doing it monthly to hopefully get these disputes down. I've talked to a few hospices that didn't realize live revocations should be reported within uh, 5 calendar days. Very important to get it done. And these are the way you could do it. First, if you filed the final claim within 5 days, if you can do it, but you may be waiting for a signature on a certification, that written certification to be done. You may be waiting on something. If you're waiting on something and not ready to bill your final claim, you can use a notice of election termination that will terminate it, put that end date on their eligibility file where it shows the term that they're no longer in hospice and they can go on and get other services. And also, another reason you may say, if they discharge on the first, second, or early in the month, you may not even have their last claim processing yet, have submitted that. So, of course, you got to submit in sequence. So you can't submit the next claim. So you may want to use that 8XB type of bill. That 8XB, that X stands for either a 1 or a 2. Charles usually goes over this in denials. And 81B is a bill used for freestanding hospices. And 82B is if you're a hospital-based hospice. But please, when you have live discharges, make sure your agency is discharging within 5 calendar days. That prevents stress on the beneficiary, other provider types, and if that beneficiary reelects to your agency 10 days later, 20 days later, and we didn't receive a discharge after that 5 days, that agency will be penalized if their notice of election is late because of that. Okay, edit to prevent overpayment of long-term stay in hospice. So I'm working with CMS and I'll talk about this with it. Summary of changes here. This closes a gap in the system which allows claims to pay at a higher rate when the admission and from date match. There were hospices out there, just a few of them, that were submitting the from date of each monthly claim as the admission date on the claim. There was no edit to check this. Effective for dates of service on or after April 1st, there now is an edit to check this. Okay, so if it doesn't match the election date on file when the hospice bills, it's not going to go through. It's going to edit, and I'll give you those reason codes coming up here. Also, when the MACs were pulling reports for specifically long lengths of stay, a lot of times they look for admission dates that are beyond 6 months, beyond 9 months, whatever MAC looks at that long stay, or 7 months, I believe is what Palmetto looks at. If you're trying to pull claims that have dates of service beyond 7 months of the admission date, and a hospice was billing the from date all the time, you're never going to be able to pull those in. So that's why this was implemented, for those two reasons, because it may have paid at the higher rate too when you use the wrong admission date. But now there's an edit for it going forward as of April 1st. So it will look back, looked at that, and we're looking at 270 days. System edit dates were circumvents to the admission date matching from date. So that's basically why this went in. We established those new edits that I'll talk about in a few minutes. I'll bring them up, and it will close that and return any claims where the claims admission date doesn't match the election date on the common working file, which would be in the beneficiary's eligibility record. So U5565 would be if the admission date does not match the election period on an original claim, and 5566 when a provider adjusts one of these claims and tries to switch the date, that will be on there. Now, to talk about this a little more and what was thought about this is an actual transfer issue, and we're working through that. As we know, after a transfer, the receiving hospice was billing their admission date, change of hospice, as their admission date. I was talking to CMS about this, and we discussed it, and we know they're going to edit if the receiving hospice bills the original election date, it's not going to go through. So we are working on it. We will try to come up with something soon about that. Of course, some claims at any time could be affected. What's happening when a hospice is trying to bill, say if they bill it with their admission date, they're going to get this U5565 or one of this edit if they don't bill it with the original election date of the other hospice or the original hospice. If they try to bill the admission date of the other hospice, the election date, it hits 37402. No claim one day through, so it's looking for the PTAN to be matching. So there's an issue with that. We are looking into that with that, and we will get information out as soon as possible. But you're going to have to, on all transfers receiving, you have to bill the original election date. It does not affect the sequential claims after the initial one after transfer. So if the Benny transferred March 31st or before, you can use the original election date. Those claims process fine. It's just the new one, the first one after the admission. So we're looking at something, we'll look to bypass this edit when possibly when there's an 81C on file or an 8XC transfer notice that matches the admission date, that this would be bypassed on that claim. So CMS is looking at it, and we'll have more information on that. We do understand there will be an issue there, and they've been working on it and discussing possible workarounds for that. Okay, editing for hospital services provided to hospice enrollees. Going back to that election addendum, this is something looking for payments for hospice beneficiaries enrolled in hospice for hospitals. This is outpatient and inpatient for hospital services to prevent duplicate payments by acute care hospitals to hospice enrollments. The Office Inspector General did an audit and improperly paid by acute care hospitals by $190 million over the 5 years they did. So this is the first edit being put in the system that the hospital can't bypass if everything goes here. So again, we want to explain this to hospices. That's why I put it in here. This does not affect a hospice billing at all. It doesn't change the hospice's billing, but they may get more contact from a hospital in this case when it denies, and I'll talk about it here. It's starting off a little soft. I took this to CMS right away because the CR creates an edit that automatically compares the primary diagnosis codes on a hospital inpatient and outpatient claims with the hospice primary diagnosis on the claim by doing exact match. Now, we all know when it comes to coding and billing, especially ICD-10 and how far it goes down, it could be basically the same family diagnosis, but not exact match. If it's not exact match, the edit won't apply. If the diagnosis code is slightly different, but in the same family, it still will process through. But if it's an exact match, we will deny the inpatient and outpatient claims. Even if they try to use the coding to bypass the hospice overall edit, which is condition code 07, usually if any Part A providers put that on there, it means it's not related to the hospice primary prognosis. So it would bypass. But in this situation, they can't bypass it. It would hit this and it's unpayable. This is where it starts. I brought this up right away to CMS and saying, we may not get a lot because it's going to be up to the coders when they're really breaking down that diagnosis of what's the correct one to put on there. And it could be the same exact family, same thing, but if they code it slightly different, the claim will still go through. So CMS reserves the right to go ahead and change that edit when they feel appropriate. So this is just where it's starting. Okay. Period of enhanced oversight for new hospices in Arizona, California, Nevada, Texas, Georgia, and Ohio. Hospice has made it into the national news left and right. You hear about California all the time. Well, we don't have California. That's with WellPoint Federal. We have Texas. Those were the original 4 states this was implemented in. And Ohio and Georgia were added on December 30th, and now we're part of this too. So we hear about California, but our Texas is our California. So Texas has a lot of issues, and I'll show you when I'm going to the cap numbers. You're going to see Texas standing out on those cap overpayments like no other state in our jurisdiction. So part of that is that. So Texas had a lot of an increase of hospices in the state, which is causing some issues, a lot of longer stays, and those items. So when they were looking at this originally, Arizona, California, Nevada, and Texas were the 4 states to go on this newly rolling hospice with a period of enhanced oversight. So that's newly enrolled in the Medicare program, submitting a change of ownership, 100% change of ownership, and reactivating after being a deactive. They're automatically going on medical review. They are notified in their enrollment approval letter of either the change of ownership or their enhance their initial letter when they're enrolled. So that's when they get to know. It can last 30 days to 1 year. Includes medical review of hospice claims as prepayment review, and the notification comes in that approval letter. So going into the extended prepayment of existing hospices in those 6 states, again, Georgia and Ohio were added in December. So CMS is looking at them also. The 3 states that are in Palmetto's jurisdiction is Texas, Georgia, and Ohio. So those are the ones we're looking at, and those are the ones that are under our jurisdiction. With this one, since they're existing hospices, they get a letter telling them they're putting on for review. If they don't respond to the request, we'll deny their claims and we can revoke their Medicare enrollment. That's a possibility. So that's very possible that we could do it. Of course, if they're, going with both of these, if they have major issues that they're getting improper payments, we do a review and it doesn't go well, they could be deactivated. So that is possible. That could happen. In the case of the extended prepayment review for existing hospices in those states, the initial round is low. So we may pull 10, 15 claims for that initial review. And if they don't do satisfactory with that, the review gets much bigger. It's many more claims. So they're going to be really looking at hospices. Again, if you're looking at the national information, the news coverage, it's talking about a lot of hospice fraud. I know it points to California, but it's not just California. Otherwise, there wouldn't be 5 other states on this, on both of these audits. So they're looking more, and they could add more states to it. Just for your FYI, this was implemented last year in October. Hospice claims billed by terminated hospices. Just want to put it in there. So reason code 32006 is the reason code when a claim is billed by a terminated hospice that go by these regulations. Technically, a hospice can bill 30 days past their termination date if the services are furnished under a plan of care before the effective date of termination. So say the hospice terminated on April 1st and is working on getting their patients out of hospice, either transferring out, they can basically bill up to say if they're April 1st, they can bill up to April 30th and still have that claim processed and approved for payment, is basically what they're on. If the claim goes beyond their 30 days beyond their termination date, that will be returned to the provider because it goes 30 days beyond their termination date. So that's very important. You can do that, but um, I just want to remember to say this: if you're a hospice and you're planning to terminate, you're planning to end your business, or the business is ending for any reason, you should probably pick a firm date and work with your patients to either transfer to another hospice, or if they want to revoke the benefit, you got to give them their choices with the state guidance says. The state will say either work with them to get them transferred or not. Don't let your census trickle down. That has a negative effect on your hospice because you're only going to have long-term patients eventually on your hospice census, and that will be negative on your hospice cap. So if you're ever thinking about termination, or you're working for a hospice, don't let your patients just wait them out until they discharge for one reason or another. You probably want a firm date and either work with them to transfer, or they would have to revoke once the hospice's termination comes up. Okay, here's the big part. Here's what we're going to go in the caps. So there's 2 hospice caps. So to ensure the cost of hospice care does not exceed the cost of conventional care and that we don't continue to pay end of life care for most of the patients that are on there. So we have the inpatient day limitation. This is rare. We hardly ever see this or have a problem. The total of inpatient days reported on both general inpatient and respite care may not exceed 20% of the Medicare total days for a hospice in a cap year. We hardly ever see that ever. So it's usually pretty good. We know like 99% of almost everything billed is routine home care, so it's very hard to get to 20% with that. If we ever found a hospice that was uh, more than 20% of the days, we just take the money back. We don't adjust claims to change it for GIP or respite care. We don't change it to routine home care. We just take that money back if that would ever occur. But this is so rare that this is about how much time we're spending on this one. The big one is the aggregated cap on overall hospice reimbursement. There's two, uh, there's two that let's see here. There's two methods, streamline and proportional methods. So streamline is the old method. You had to be enrolled as a Medicare hospice prior to 2012 uh, when proportional method came around. So every new hospice is automatically proportional, and just the majority of the hospices do that. Hospices are not allowed to switch back and forth between cap calculation methods. It was complicate the cap determination. Only hospices using the streamlined method may change to proportional method. You can't change to the streamlined method at all. Once you're out of that method or you were never allowed to select it, you can never select it. The most important thing, and again, we always know about this, is to be eligible for the hospice care under the individual must be entitled to Part A and certified as terminally ill with that expectancy of 6 months or less if the illness runs its course. It's very important that that 6 month or less expectancy, that most beneficiaries that elect hospice are in that range. And I know we're looking, I mean, CMS, Medicare, we're going to be looking at those long lengths of stay more and more. I mean, I know Charles was talking about it. You know, cancer, once you stop curative, most likely your body's going to shut down one way or another from the cancer, your organs somehow. So we know where that's going. That's why we look at non-cancer lengths of stay rates. We have more of this dementia or Alzheimer's. We have uh, heart failure in one way or another. These are things that the patient has been going through for probably a lot longer, as Charles mentioned, than uh, just something that happened in the last year or more. This was probably going on for years. So what makes them hospice appropriate now? And those patients are living much longer. So you want most of your census to be in that 6 months or less or total hospice over their lifetime. We get a lot of feedback on this. We get pushback. New providers are the ones that really have the hard time with the cap calculations. They admit them, and they probably had patients had a lot of hospice before, which is, affects the cap. And I'll take that breakdown going on here. But they'll say, well, the patient was certified. We certified them. They meet the requirements. We have everything documented. Everything looks good. We went through medical review and you approved it. Why do we have to give payment back that we're over the cap? Well, it was explained to me like a car. You need to have insurance in your car. You need to register your car. You need to maintain it to make sure it works. You got to make sure the brakes are good. Just because you have all that done doesn't mean you can go over the speed limit. And that's pretty much what the cap is, going over the limit of what we pay per patient through the hospice benefit. Aggregated cap on overall reimbursement. The hospice's aggregate cap is calculated by multiplying the statutory cap amount, the national rate, by the count of Medicare beneficiaries to a specific hospice in years. You have to get information and reports out of the PS&R system, your beneficiary count That is super important to find out there. In the calculation, Medicare payments are compared to the aggregated cap amount for that. Payments more than that are over the cap are overpayments and must be refunded to the Medicare program itself. And just know that national cap rate, and I'll bring it up here on this next slide, these are national. These don't have wage index changes for the region they're in. So Dallas, New York City, Irmo, South Carolina, where I live, Shreveport, Louisiana, Baton Rouge, it's all the same amount. It's the same no matter where you are. It is the same amount. Jackson, Mississippi, all those places, it's the same cap. It doesn't matter, that maybe those bigger cities get paid more. The cap is the cap. And when you really look at these figures, if you took the routine home care rate with this first 60 days paying at a higher rate and basically the last 4 months paying at that lower rate, it's almost that cap amount of the national rate. That's how it's figured out. Pretty much 6 months of routine home care is what the cap does. So if the agency's billing other level of cares, you're billing a lot of respite, you're going to meet that cap quicker. You're billing doctor services on the claim, or say the nurse practitioner was the hospice, was selected by the patient to be the attending physician, and they're being billed on the claim too. All that goes towards the cap amount. Every payment that the hospice gets per that patient goes towards their cap amount. Everything's included that's paid to the hospice on the hospice claim. So it's gone up every year, that effect. Here's looking at the overpayments. I have 2023 and 2024 on the next slide. So I highlighted Louisiana and Mississippi for the presentation here earlier. It's not highlighted on your slide, but you still have the same information. In 2023, Louisiana had 122 total hospices. All 22 did caps. 13 were identified with overpayments. The percentage of those, so that's 11% of the hospice population, was found to have overpayments. The total overpayment amounts for those 13 hospices were over $4 million, almost $4.2 million. And if you would average it out through those 13 hospices, that could have been 300,000 plus for each of them. That's just an average. That number probably is not true. One hospice could have way more than another hospice. Mississippi had 90, 10 with overpayment. So again, that doesn't make sense well, yeah, it does, 11%. So that's almost $2 million that had to be repaid. So you can look up all our 16 states here up and down. And when you get down to Texas, that's 87 million, the state of Texas, their hospices had to pay back. The next closest one is, let's see here, is Florida with 13 million. When we look at Florida too, it says total hospice is 52. That's provider numbers we're looking at. So Louisiana has 122 hospice provider numbers that are actively billing. Florida has 52. That's because they're large. There's 4 large companies based in Florida that use the same provider number. So don't think it's the same that Louisiana actually has more hospice or Mississippi has more hospices than Florida. That's not true. It's just they're bigger organizations that bill under one provider number. So, but Florida is not that far behind Texas with hospice and billing and just the amount of patients on hospice, but there's $74 million difference in those overpayments. That probably comes because we're looking at 968 hospices total. And when we go to the next slide, you're going to see a massive jump in the Texas hospices. So 968 goes up to 1,049 in 2024. That's how many hospices were included. So, and the payment rate went up. $121 million they owe. So Louisiana went down a little bit. Mississippi went up in these rates for their We have one less hospice in Mississippi completed because they probably went out of business or terminated. So they don't count towards this information, but there's still overpayments with that information. So just good numbers to put up here, just so you can see the difference. It's gone up each year going back. So overall, $167 million in overpayments due to the caps in 2024. And then we go back to the previous, it was 128 million. And again, Texas took a huge jump, 87 to 121. So that's 30, $2 million or $35 million, somewhere around there. That's a big jump. So it wasn't getting any better in Texas. They have a lot of patients that were on for more than 6 months. Again, if the average census in Texas is more than 6 months or the higher, we're going to see more overpayments. So big information there. And this is just a good look. Look at Kentucky. They're 0-0 on both. The reason Kentucky, they probably have the most restrictive certificate of need of hospices in our 16 states. So I know Charles shares data a lot of times with the average length of stay. Kentucky's is like average of 20 days shorter than any other state in our jurisdiction on average. So they are always zero overpayments, and they are more right on because they have much less hospices covering their area. They have a really, really tight certificate of need, is what happens there. So in this case, Tennessee didn't have any overpayments for 2024 either. And at the end of February, very beginning of March, the self-reporting cap were due. And of course, we're just starting to work through that. Plus, we're still having claims process for last year, so we don't do that. We can't come up with the 2025 of where we stand yet. There are cap gurus here at Palmetto-GBA are working on them right now to do that, but this is what you can see numbers and really see which states have the highest overpayments in our 16 states. So how does it work? The proportional methods, which applies to most hospices. A beneficiary receives a lifetime count of one. A proportion of this count of one is allocated to each year in each hospice that provides services to that beneficiary. So it is a lifetime cap. I know there's a lot of confusion where it says, well, here's your annual cap amount. Well, that's just the cap for that year. If a beneficiary was just in that year and that's all the hospice they received in their lifetime. So if a beneficiary admits on April 1st for the first time in hospice and they pass away on April 19th, of course, they're not going to have more hospice because they died. They passed away. They got 19 days of hospice. So with that, that is going to be all of it. And that hospice will get that full allocation of one, not a payment of that full cap amount, but they get that full allocation. So if you have a patient that stays on 19 days total on your census, and that's all the hospice, they get that full allocation of this year of that 35,000. And if you get another patient that was on for say 8 months, which is going to go over the cap amount, and they pass away, and all their days were in this year also, between those two allocations, you have about $70,000. As long as the hospice between those two patients wasn't paid more than $70,000, there's going to be no overpayment. That's the way to simplify it. If you can take on some of those patients that are going to have long lengths of stay, as long as you're having patients, with an average or shorter length of stay too, the ones that meet it. So that's basically how it works. And I have some scenarios here, or case studies. Patient, doesn't matter the year. I know it says 2001. It doesn't matter the year. Patient elects hospice in 2020, receives 120 days from hospice number one, January 1st through April 30th, and expires on April 30th. There's no more hospice coming in. That's basically 4 months of hospice pay, hospice payments from Medicare. And if you're averaging, say, $4,000, $4,500, you're going to be in 4 months, you're going to be around $20,000 maybe 15 to 25, you're going to be under that cap. But you get that full allocation for that patient. The allocation, all that extra allocation may be able to use to a patient that stayed longer. So no later revisions on that. Here's 2 years. Patient expires. Lex Hospice from 8/1/21 and expiring on November 28th, 2021. So they're passing that October 1st date. So they're going to split into 2 hospice years. And that's what's going to be all. Patient expired. There's no other hospice to be billed. So again, this is 120 days. So you'll know you'll be under the allocation. You're going to be under that allocation for this patient. But that allocation is going to be split into 2 years. So in 2021, they had 61 days. In 2022, they had 51 days in hospice using those dates we used before. So in 2021, the hospice will get a little bit over 50% of the allocation of that benefit. So say if that's, I'm going to use a round number, that the hospice cap was 30 grand, they'll get about 15 grand of the allocation. So that's for 2 months. So most likely you're going to be under in payments. They almost did this evenly, so it's about 50% that will be counting towards 2022. So that hospice will get 50%, rounding it off, of the allocation in 2022 for that patient. So, it doesn't restart the cap year. It doesn't start. We go back 18 years, 19 years, looking with the beneficiary. We can go back that far when we're doing the cap numbers, but we only do a look back and adjust actual cap figures only every 3 years. We only go back looking 3 years, so we can change the cap numbers going back 3 years. When we're doing our next cap year, we're doing a look back for the previous 3 years. 2 hospices over 2 years. 92 days of hospice in 2021, 45 days from hospice 2 that go into 2021. So basically, total days is 137 for all years. And that's going to break up into the 2 different cap years for those 2 different hospices. So let's say 45 days in 2021 they had. That hospice is going to get 32% of that allocation to figure towards their aggregated cap. And hospice number 1 in 2020 is going to get 67% in 2020 towards their allocation of the cap in 2020. So very interesting, these numbers. And these numbers change as more claims are billed or possibly had medical review. And we'll talk about that a little more too. So a claim audit effect on the aggregated cap, a claim audit on one hospice could benefit another hospice. It could be a temporary benefit because of the success rate of the appeals. We know that when it goes to the administrative law judge, there's a chance you're going to get a more favorable appeal. It just is that way. A lot of times, by the time it gets there, the patient has deceased by that time. They passed away, and they're more stating to say, well, they died, so we'll allow this. Not that it met the rules, and maybe it was denied correctly for not being hospice appropriate in the beginning, but by the time you get a year down the road to get to the AIG, not the AIG, the administrative law judge, that patient could be deceased, and they're more favorable to overturn it because the patient has now died. So that's a lot of why currently that the ALJ may overturn, where we in the initial appeal won't, and the quick won't, or the quick won't overturn it in the second level of appeal too. When looking at the documentation, we're going directly at what the rules are with that, and not the patient, passing later on. So in that case, say if a patient was on a hospice, say a hospice for 2 years with a couple different hospices, and the supplemental review contractor takes the other hospice's records and say, hey, you don't meet the requirements. We are going back and denying all your claims, which adds that back, all that money and all that allocate, all those payments, and takes off all those allocations off that. So the other hospice may be a beneficiary to that, but we won't refund that until all claims are out of appeal or in their final collectible status is when we'll adjust that, and maybe we'll reimburse you on some of your cap overpayment if you had an overpayment prior to that for that cap year. So we could do that. It's not a dollar for dollar amount. It doesn't figure out that way. So that can't be figured into that. So self-reporting, each hospice has to do it 5 months after the end of the reporting year, which would be the end of February. So that's when it's done. You must, every hospices must submit it, their own self-determination hospice cap report. If we don't receive it, we send a past due letter within 7 days, and payments will be suspended at 100% if you do not submit your self-determination cap. So that would go on in early March if it wasn't received. Um, so you definitely want to get that in timely. It's almost like 20% of hospices don't have it in timely and will have some type of payment suspended when it comes due time. Or we do get a lot in early March, so maybe not that many are suspended. But I know 2 years ago, I think it was close to 20% we sent these letters, past due letters are out, and we suspended a lot of the payments. If any questions about the self-determination report submission, you can email them to hospicecap@palmettogba.com, where our cap gurus will be happy to answer those questions. So you have to pull reports out of the PSNR system, including the beneficiary count reports, which are using or preparing the self-determination report. So this will change as more claims process or adjusted for that fiscal year for hospice. So you probably want to wait as late as possible in the February to pull that report for that year. Always receive the port identification period with a from date of the first day of that reporting period, which is always going to be October 1st. And the through date will be September 30th. That doesn't change. You leave that it is because you're looking for payments for those days and those beneficiary accounts. Pay dates, leave that as the default setting of the date you're pulling the report. If you change it to the through date, you're not going to get claims that paid during that period that were submitted later. You want to leave the entered pay dates, the date you're pulling that report, that it will pull claims for that time period, the from date of October 1st through September 30th of that year, but it will make sure it counts the ones that were dates of service between that year that were paid in October, November, December, January, and maybe even February that they processed. If you're getting your billing done a little bit later, if you're doing that. So very important there. Always leave the pay dates as the default setting. If you put it back to September 30th, you're going to miss all those claims that processed after that year. So make sure you have access to it. And also with our information, there's also a way to get the reports through our Cap Gurus. Same email address that I had before. There's no forgiveness for going over the cap. It has to be paid. There is no hardship at all. You have to pay it back. Every hospice does. So there'll be an overpayment letter that will come out saying you owe this much. You are that far over the cap. You owe this much. You must repay it. You can request an extended repayment schedule. That does not pause interest. So you have 30 days to pay it back in full from the date of the uh, overpayment letter. If you don't repay it back, interest starts from that point on. And I'll show you later in e-services where you can see that information. Recap on hospice caps. Hospice with patients that average 6 months or less on hospice in their lifetimes are less likely to exceed the cap. Each beneficiary has a lifetime allocation of one for reimbursement in the hospice benefit. This count of one is allocated to each year in each hospice that provided hospice services. The reporting has to be done. Self-determination has to be in by the end of February, usually. We say that. But this year it was due March 2nd because the end of February fell on a Saturday. Sunday was the 1st, so we allowed it through March 2nd to be put on there. And yeah, this helps too. Say if a patient, you got hospices out there that may be more willing to discharge as no longer terminally ill after they get past 6 months. You may have those hospices that are looking at to possibly game the system and hope that the patient doesn't go back on hospice. But say if they were on 2 years ago with a hospice and now they're electing with your hospice, you already know they're on it. You know this could be negative against your cap, but we're going to be pulling some of that allocation. The more days they stay on your hospice, we're taking the allocation from the other hospice. The percentage, their percentage of the allocation is going down and yours is going to go up, but still it's going to be a shared allocation with that. So where you find it, if you go to our hospice information, plus there's more information and more scenarios there. You go to topics, you go to audit reimbursement, and then you select the hospice caps, and it explains it more about the caps. But here is your cap resources. More case studies are there if you want to check it out. So they are all available. And as Charles mentioned, probably, I don't want to say I didn't hear him mention it, but he probably always does, is that we are having more denials for patients that are not hospice appropriate, do not meet the requirement of the benefit. That's probably one of the biggest denials we have now. And when I see the documentation or what the nurse reviewers write in Targeted Probe and Educate or something to that effect, or any type of review, is yes, the patient has a disability, but at this point, they need help, but there's nothing showing that they're terminal and meeting and all the documentation, they're stating that we're not finding that's basically meeting that 6 months or less. We're not finding that terminality in that documentation. So those denials are coming up more and more. All right. The eServices portal, it's always great to offer eServices, our free, friendly, internet-based portal. I know we just got through tax season was due, I guess, 5 days ago. This is truly free, where that other tax billing information that they say is free, free, free is really not free. If you want to do something electronically, submit your tax information or get a payment back if you're due a refund from the government, yeah, that's not free. They always charge you for that, but eServices is free and it does a lot of things. Eligibility, that Medicare beneficiary identifier, the MBI lookup tool. I always say to the billers, use this when you're going to bill the notice of election. You have 5 days to bill that notice of election from the date of election. Make sure that MBI is right, because if it's a terminated MBI, it's going to return, and then you're going to have a possible issue with a late NOE and having penalties on it. So while you have play time with claims, you have the year to bill claims without penalty, you don't have a lot of time to bill the NOE without liability. And if it changed more than 2 weeks before the admission, we are not allowed to give a bypass of the late or allow an exception if it was more than 2 weeks prior to the election date or the admission date that the MBI changed. Lots of different information. We'll look at different things. E-delivery, get your information electronically. As I mentioned this morning with the home health agencies, that they are going to be looking to get away from faxing definitely, and probably mailing too, with any type of documentation in the future. Dr. Oz, so he mentioned it. Definitely fax. I saw was going away. I believe in 2 years there will be no more faxing. of information from providers. It would have to be submitted electronically. Um, so he made the joke that the 90s are calling for their fax machines. They want their fax machines back. So the faxing is definitely going to be out, and maybe other ways are going to be out too, where it has to come electronic in this day and age. So administrators, multiple administrators is definitely something you want. You need a backup administrator because that's how important they are. Because only the administrator, uh, well, let's start a little bit earlier. Who is the administrator? Only one person can register the PTAN MPI combination for e-services, and they automatically become an administrator. They can add, they can administrator users, they can add users and other things within it. So they grant access for provider users to access so that one person signs up, and anybody else within inside the agency that needs access, that administrator would give them access either as a user or as administrator themselves. And the big difference, the administrator has access to everything in e-services. All tabs are available to them. So the administrator can see everything. And then users, they can have their access curtailed to items that maybe the administrator doesn't want them to have. So that's what can be done. So they creating the provider user, they would do that, assign a temporary password. E-services comes up with the user ID. We have to do that so they don't overlap. Assigning application permissions to anybody that's set up for a user. Like they could have them available to do the MBI lookup, eligibility, but maybe they don't give access to the financial tab, something like that. They can create additional administrators. They can modify a user's profile, say that down the road you want to give your user more access. You can do that down the road. Terminate provider users or provider administrators. That's the big thing. Anytime somebody leaves your agency, you want to get them out. You want to terminate their access, and only administrators can do it. So if one administrator leaves, you want another administrator to be able to terminate the administrator that left, so they have no longer access. This is an internet-based system, and anywhere you have internet, you can get on this system with that, as long as they have up to date, the latest browsers, things like that. You can't use older browsers and items like that. The system just doesn't work on it. They can also unlock users or additional provider administrators who will lock themselves out of the system. They can recertify their users, and administrators are the only one that can select e-delivery preferences, your green mail, your ADRs. Do you want them? Do you want your TPE letter to be sent electronically? Different items like that you can set up for electronic delivery with that. So they do a lot. Uh, why multiple administrators are recommended, and we're putting this together because there's a lot of providers that have one administrator, they leave, they lock themselves out, or they do something. It can't be fixed because there's no other administrator to come in and fix it. You're going to have to call Palmetto-GBA through our EDI and get that unlocked. So it's better to have two administrators. Plus, if that one leaves and they delete themselves, that deletes all users underneath. If there's one administrator with a bunch of users and that administrator gets locked out or terminates their access, all users underneath it lose their access too. So yeah, ensure somebody available, say if they're overlapping or they take different times off, you can have two administrators to help out. One thing too, maybe you haven't used e-services, maybe you had it a few years back and you didn't keep it because you had to log in every 30 days to keep your access. Well, last year what we educated on is no longer do you have to log in every 30 days to keep your access. Keep your email up to date, and if the system sees you haven't logged in 20 days, it will send you an email, and all you do is click a link and it will reset it for another 30 days. So that's a big improvement, because before we did that, you had to log in. You had to get your authentication code, request that, put it in there, log in. So you had to get your ID, password, authentication code, and log in. That may have taken 5 minutes for you to do. Or it's something you may have put on a back burner till later and just forgot about it, and then 30 days passed and you lost your access. Now you just get that email. As soon as you see that email, click on the link, a window pops up and says, you've reset it for another 30 days. You want to do that as soon as possible when you get that email. Don't let that pass 30 days, because it will suspend your access. We're also looking at, and CMS is looking at the fraud concerning malicious actors stealing MBIs and using them to commit Medicare fraud. And within some agencies or some providers, there could be those actors working for an actual provider and doing it on the side as a side gig. So you could always have one of those. You don't know. You hope it doesn't happen to you, but they could be doing that. Um, it's lucrative to sell the beneficiary information so bad actors can bill, get that money, and disappear with that money. So CMS noticed that they're implementing enhanced monitoring controls to prevent this abuse. And we have here the MBI lookup enhanced monitoring. Um, your agency should only be using it for patients you plan to bill for. Is this what comes out for? It will be comparing MBIs against an actual claim submitted with the MBIs. And if there's an unusual high rate of MBI lookup without associated claims, the access to the MBI lookup tool could be removed. Now, this would be rare unless they find that high rate. We know that you could get a referral. You check that patient, you already see that they're on hospice. The patients talked to, they don't want to change hospice, so you looked up their information already, that's fine. If it's happening 100% of the time, that's going to be kind of off and look. So CMS determines that. Um, we we don't know what it would look like, but it would have to be an unusual high rate of not billing for that. So another thing to think about is if you have multiple agencies and they're all connected, because you can link them all together in one login, that if you're doing this entitlement or these MBI lookups, make sure you switch it to the unit that they would be going to their MPI and provider number combination. So make sure you're looking at the correct one and you're switching it. And you want to see the warning every time you log in, it's going to be there. So it's put there. You can see your overpayment balance. If you're looking to see how much you owe on, say, a cap overpayment, I'm just going to use that. There's financial tools, there's overpayment data. You just put in either the transaction number, if you have an AR transaction number, or demand letter. Say you got the cap over demand, you can just put one or the other in, hit submit, and it comes up with the balance. So this is actually from claims itself. You can see the remaining balance on this is $214,000. So this provider had an audit, I think, from the SMRC in this case. This had on the bottom right here, we're looking at overpayments. 47 overpayments were on the demand letter, so that's usually 47 claims. And it shows you what the interest amount, what's remaining, and that information overall. Medical review. Please use e-services for your ADRs. You'll get them faster. You can also, if you request your medical ADRs to come through e-services, there's in e-delivery, there's another box to click. Do you want an email alerting to you that you have an ADR in the system waiting for you? So you can get that kind of alert instead of looking for them. You can get something sent to you saying you have one in e-delivery to go take a look at. There's an ADR out there. So it's best to uh, select to submit your forms or responses to medical review in e-services. Just a great way to do it. It's much faster. It gets to us faster. Again, no paperwork. You can pull electronic document, save it as a PDF, and attach it in the e-services. And you can separate it to help our reviewers make the determinations. If you want to, if you need a face-to-face, that's a period you had a face-to-face if we're pulling the claims for, you can document the face-to-face and name that document and attach it. That way the reviewer says, oh, here's the face-to-face information. Plan of care information, attach that. Certifications. Here is the certification for this period. You can attach that separately. Everything you can attach and help the reviewer find the information and make that information stick out. So it's really good to submit it. That is excellent. We've had some enhancements in February. We have had 2 enhancements in the claims. If you look up claims, there's multiple different ways to look up claims. You can look it up by the patient's MBI. That will bring up all your submissions for that beneficiary, the NOE, all claims billed, even if they're returned, reject, any of them. You can do it by date of service and MBI, and that will narrow it down. So you can select what you want when you're going to claims. But here you go. So line level reason codes, we took the information that will come out of DDE, what the provider would see in DDE, and now have that coming out in e-services. So the dreaded U5211 rejection code, our records indicate the services billed in the claim were provided after the beneficiary's date of death. I know probably most hospices have seen this. This is one of the hardest things to get fixed. And I always talk to hospices. If you're billing a patient with a patient status code of deceased, make sure you get that date of service, that date of death correct, that you bill it right. You cannot adjust that out of the system. Once it's submitted, that date of death will go through all Medicare systems, A, B, everything, and up to Social Security. And the only one that can fix it is Social Security. We can't take that out at this point. So that is just the way it stands at this time. So, but back to this, now you can drop it and see the reason code, uh, full narrative that you would see in DDE. The next part, still being in the claims, in this case, you want to know, well, what's the date of death? We have a service date of 9/21. So I'm going to review eligibility. I want to click on that right away. So this takes you to the eligibility page. Automatically puts the last 2 years of data in here. I mean, for searching historical stuff, and the beneficiary's last name, first name, and Medicare ID, so their MBI number. I did not realize this. I used to work in the call center where anytime you called, we asked for first name, last name, Medicare ID, and date of birth. But for e-services, either you can have the first name or date of birth. You don't need both, one or the other. So it works with only 3 items for verification, but those 3 items have to be correct. So very important there. And now, anytime you go to our eligibility page, we are pre-populating historical data date ranges. It's so important to have those in there if you want historical data back. So important. It matters if you're looking to see if they were on home health and it doesn't overlap the date you're doing the search. Say you're doing the search today and it's automatically populated from April 20th, 2026 back to April 20, 2024. Leave those dates in there, or you can switch it to 2 years beyond that too if you want to do a check for older status. But say you want to check to see if they were on home health, you need a date range as it's not going to pull up. If you don't have a date range in there, it only pulls things up that overlap today, except for one thing, I believe, is hospice elections. It won't pull up the benefit periods, but it may pull up the hospice elections without a date range. But now we put them in there so you know, because there's too many errors of providers not using the optional fields for requesting historical data. So we're pre-populating it all the time to help curb some of the eligibility issues we're seeing with claims. All right, TPE. Quickly over this, we got about 10 minutes to go. This has been the medical review process for probably about 8 years now, and it's much better than the old process. I mean, when I first started, if you submitted the records and you forgot the plan of care, we denied it for no plan of care. We just denied it and didn't go any farther. Say if you didn't have the face-to-face and we saw you didn't have the face-to-face, we denied it and didn't go any farther. And then you could appeal, and then we would maybe deny for something else. So we never went on. In Targeted Probe and Educate, we review the full records and make a determination of everything that could possibly deny the record or deny the payment. And if there's easy curable, we reach out to you. We'll call to you. Say if the face-to-face was missing or the election statement was missing. Uh, we will reach out to you and see if you can submit that, usually within about 5 days to the reviewer, 5 days or less. They're reviewing the record. They don't want to have a bunch of open records, so that it's limited time you got to get it in. Uh, we'll take that information late and we'll use it. And if it meets the requirement, we won't deny for that later. So way better. And plus we give education at the end. So first it starts with data analysis. We look at what the cert's doing. What is the cert denying for? We look for, long lengths of stay. One agency is billing way more GIP than other. Those are all things that we'll put reports. There's a lot of open hospice TPE audits going on. So they're all for different reasons, and we'll look for um, the top percentile of hospices that are high in that information, and we could audit them on a certain piece of information. We send you a letter, reason for selection, how this process goes. We start submitting ADRs or generating ADRs. We'll give you, once they're submitted, if you submit your records, we have 30 days for prepayment review and 60 days for post-payment review from the data documentation is received to make the determination. That doesn't mean the claim will be paid. If you submit the documentation on day 29, uh, or you have 45 days to submit it. If you do it on day 40, we have 30 days from the date you do it to make a determination to put that in the system and let the claim process out. It's still got to go through other edits. It doesn't mean the claim will be paid within 30 days of the date we receive the records and the prepayment. And then we have the cycles. We have up to 3 rounds, 20 to 40 claims per round, unless for some reason the agency who was high on billing GIP all of a sudden stops billing GIP. We've seen that happen. They go on a GIP audit, all of a sudden claims don't come in for GIP anymore. There's nothing to review. This happens. So if there's a long lull with no GIP claims that meet the requirement, we may end it early at that point and do less than 20 claims, which is going to be hard. If you do have a couple denials and we do less than 20, that 20% denial rate is quicker to get to with less claims. But that's something we've seen where when we did our data analysis and pulled data, they were billing GPE a lot, and then all of a sudden they go on a GIP audit, and all of a sudden we're not getting GIP. Their billing has totally changed. That happens in all different ways. So that's probably the only way we end at less than 20, that 20 to 40 reviews per round. The error rate's 20% or less. If you are 20% in claim denial rate or uh, payment denial rate, you get moved off that and you won't go on that same audit for at least a year. But if you are over the 20% or either of those two, we'll give you education in about 45 to 56 days. And after the education, we give you about 45 to 56 days to fix your deficiencies, and then we'll go to round 2. So Don't set up the education with medical review. Don't cancel it or push it back, because once we set it up the first time, or if the provider's not answering, we're going to set a clock and start counting. So take that education as soon as possible. And what these 3 rounds are expecting is the provider's going to do better each time. No matter what provider type you are, we're expecting that provider to be better and know the deficiencies. And when we do round 2, we're expecting to see less denials. If it's more than 20% following round 3, we have to refer to CMS what they want to do. Do they want to go round 4? Do they want to go to a U-pick? What do they want to do? It's going to be CMS's decision with that. So lots of information on that. Provider enrollment, make sure you're looking at your revalidation. This revalidation list here, look at it. It will tell you, it will post to that 7 months before the revalidation is due, which is going to be at the end of the month that it's stating it's due. It used to be every 5 years like clockwork, but the pandemic threw that off. But now it's going to get back on that 5 years. If you just did one last year, it's probably going to be 5 years that it was due that your next time is going to be due. If it has a to be determined date, that TBD, you're not due. Do not ever submit an application unsolicited. If you're not due, we will return it. If you have changes that have to be made, like an address change, and you're trying to wait for a revalidation, submit the application as a change of information. If your revalidation comes up while we're processing that, there's a good chance that change of information will be turned into a revalidation, and we'll just kill 2 birds with 1 stone. But don't submit an unsolicited when there's no date to be on this website for you to put it in. Don't do it. We will mail you or send it through e-services, a hard copy one, but that's only up to 90 days prior. So it's always better to use that revalidation. Set a reminder maybe every 2 months to look at it. If you know you just had one last year, maybe set the reminder out in a couple years to go look back at it, because it's only due every 5 years. With the tool, all you have to do is enter the MPI, and it will come up, and if it has a due date, get your application in prior to that due date. Don't be late with it, else we're probably going to put you on a stay of enrollment. So failure to revalidate, hold on your Medicare payments, or an interruption of Medicare billing, because first you'd be placed on a stay of enrollment, and if you don't act on that, it would be a deactivation. So um, let's see here. Stay of enrollment is a less burdensome on providers and suppliers if deactivated for revocation. It's a preliminary earned term status, a pause. We can only implement a stay of enrollment if the following 2 factors occur. Is non-compliant with at least one Medicare enrollment requirement. That could be failing to revalidate or failing to update your address, which has to be reported within 30 days of that change, and that the non-compliance can be corrected by submitting an application. If your hospice is deactivated by the state by a survey, a substandard survey, that can't be reactivated with an application. And a stay of enrollment wouldn't be going back on. If you're put on a stay of enrollment, you'd be put on a stay of enrollment for missing revalidation for 30 days. Admission dates within that stay will reject with reason code 39998, stay of enrollment. Once the stay is removed and you're back in compliance, do not adjust those claims. Go ahead and resubmit new claims for those to get them processed. All right, deactivation or revocation. You don't want to get that far, because your notice of elections are not going to process if they're past your termination date, and you may not get them granted in a late exception if it's actually the agency's fault for the termination, for not revalidating properly. But that's only if that's on the agency. If we made a mistake, we should be granting it. All right, the CERT. The CERT is one of the older outside review contractors. They do random reviews. They'll pull one claim. They'll review it. If there's a problem with it, They'll work with the provider to see if they can get documentation, but say they go ahead and deny the services, they go on to the next random claim on the next hospice provider. They don't put a provider on audit ever. They go to the next random claim. But as a MAC, we look at the results and see what they're finding, and we could do TPE audits based on their findings. So that's super important there to know. Lots of information. They measure payment accuracy, improper payment rates by MAC. So if one MAC has a lot higher improper payments, that could be bad for that MAC. They could lose their contract. So that's why it's so important to us. Not only are they measuring the improper billing or payments to the provider, they're looking at the MAC who's allowing those improper payments to be paid. So that's why we have to do our medical review, because we always got to protect the Medicare Trust Fund. Any of these reviews, number one thing is ensuring proper payments and protecting the Medicare Trust Fund. Here is a website for you, so you can go see that. You can log onto that, just good information. The submissions, again, fax is going away at least in a couple of years. I'm sure faxes. I don't know about mail. People have been saying mail's gone too. I thought it was just fax, but it could be mail also. Please respond to them. Do not let it go out. If they don't get a record, they don't receive it, and they try calling, they'll do everything to get you to submit those records. If you don't submit it, we're going to deny it for 56,900, no records received. Make sure to avoid cert areas. We really don't want the cert denials, and we'll help out with that too. So we got lots of different resources, just good cert information. And then all kinds of educational resources here, provider communications, hospice code of federal regulations is great too, but the benefit manual and the processing manual is the way I answer most of my questions. Then we have on CMS's website, they have an example election statement and example addendum statement. All kinds of different job aids. In the first one, I sent this out in the chat, hospice billing physician. This is the decision tree. Can you bill this physician service? And if you're billing an NP physician service, you have to put a modifier on there because they don't get 100% of the physician fee scale. It's reduced to 85%. So make sure you're doing this. This second bullet, hospice to report post-mortem visits with the PM modifier. If an RN stays after the pronouncement of death, say it's 6 p.m. and they stay to 8 p.m., but they were there at 4, so they're there for 4 hours, 2 hours prior to death and 2 hours after. That's got to be split on the claim. The PM modifier goes with those 2 hours after. Why would that be? Because if it was death occurred in the home on routine home care, you get that extra service intensity add-on payment. If it doesn't have the PM modifier for the time period being after death, that's an improper payment. So just lots of good job aids. Make sure your billers look at all these job aids. If a notice of election is submitted with the wrong admission date, you can correct that without canceling it. And this job aid talks about that. And the benefit of that is we'll still keep the original NOE's submission date as the date received when you submit the corrected NOE to correct the date. So you may not have a late NOA from that. So very good information. Chat with Sage. She's the claims person. I don't know if you would use that much, but you can use this for claim information with it. Chat, stay connected to us. As Charles said, I don't want to hold you up anymore. I know it's 4 after 4 in Central Time, but please do our surveys. Just as you note, and as Charles mentioned, everything's 1 out of 5 except for this one question that goes to 10. I guess they're trying to keep us sharp is what they did with CMS with this. But just give us your true feedback. Just understand if you're zooming through it, there is one question that goes to 10. And if you were truly satisfied, they would like it to be 9 and 10. But if you're not, tell us the truth. We're asking for you to answer this honestly. Just know that one question does go to 10. So with that, I'm looking, I still don't see any questions. Are there any questions?
I'm looking in the chat box. I don't see anything in there, but
Yeah, it's a
uh,
lot of information. I can get
yeah.
long-winded about hospice, that's for sure.
Yeah. Well, Dan and Charles, we really appreciate you spending the time with our group to give us these clarifications. And um,
Well,
I, anybody before we close up today, does anybody have a question for Dan? Well,
yeah, we're
Dan,
hoping you got something out of it. Maybe there's a piece that you were thinking about or never knew about. Even that helps. It takes you
yes,
out of that situation of maybe where you don't where you don't get in a bad circumstance with something. And hopefully if we even gave you one thing to help you do your job, we're happy.
thank you, thank you. Well, we appreciate your time today, and folks, you should have found the handouts in today's calendar invite. If you did not get those, if you don't see them, please let me know, and I'll be more than happy to send you the handouts for today's session. With that, thank
Drinking
you.
from my South Carolina cup too, my Gamecock. Sorry about that. I couldn't find an LSU. I couldn't find an LSU one fast enough.
Thank you, thank you, and we'll see you again next time.
Absolutely. Thank you, Jamie. Thank you,
Take,
everyone.
take care. Bye
Yep.
bye. Bye,
Bye-bye.
Charles.